Hey everybody, we're just gonna wait maybe 5 minutes and then we will get started just to let some people join in, okay? Okay, hey everybody, we'll go and get started. As usual, thank you all so much for joining. We really appreciate it. We've had the best support from all of you guys through, Instagram comments, messages, all that stuff. We really appreciate it. We've been able to put together a lot of good presentations and collaborate with some awesome PAs. Today especially, I think you'll notice we have a really good one. She's very sweet, incredibly informative. We're going to have a lot more sessions coming up, so you guys will be able to get a lot of information, good information, experience, that kind of stuff. And most importantly, shadowing certificates. Just kidding, but yeah, that's going to be a nice part. So we'll have those dates posted maybe tomorrow. We'll have a lot in November here, so just stay posted on that. I know a lot of you guys are wondering about the quiz and certificate, so I'm going to let Alia talk to you about that.
So for the quiz, we'll send out a link at the end in the chat that you should see to the right of the video, and then it'll be open for 1 hour after the session has ended. We'll also put a link to that in our bio on Instagram. If you pass the quiz, you will get a certificate within about a week, and to pass, you need to get at least 4 out of 5 correct.
Awesome. So we're just about to go ahead and get started. One thing is, if you guys have any questions at all the entire time, feel free to ask. We're going to document all of them, and we'll try and present them to Spencer as she goes if we can, but if not, we'll make sure to ask all of the questions we can during the Q&A at the end. So please, we want you to be active in the chat. So far, it's great. Everybody's being really nice, saying hi and all that stuff. We love to see that. But okay, we'll go ahead and get started. Spencer, if you're ready, there's about 125-ish people watching right now. So whenever you're ready, you're good to go.
Cool. Let me do this. And then this. Can you see my presentation and hear me okay?
Perfect, yep.
Beautiful. All right. Hi, guys. I'm Spencer. I'm a hand surgery PA in Southern California, where it's nice and dark at the sharp hour of 6:45 tonight. I apologize for all of you on the East Coast that are up late, but here I am still in my office. So I was just going to start with a little bit of background information about myself. I was born and raised in Southern California. In high school, I had the incredible opportunity to work in an exercise physiology and kinesiology lab doing research on jump and land technique in college volleyball players, one of which I happened to be later in my life. And I think that really got me interested in mostly clinical care. I was more interested in actually doing the documentation of the players doing their motion than I was running the numbers on their research afterwards. Nonetheless, I went on and played volleyball at Brown. I graduated with a bachelor's degree in human biology with a focus in human health and disease. That's relevant only because Brown has an open curriculum, so I didn't have any biology classes really when I applied to PA school, which makes things a little challenging. At that point, kind of my sophomore and junior year, I felt like I was interested mostly in medical anthropology, looks at why disease affects different people in different ways. I spent a summer doing actual research at that time and realized that I really just didn't like research. And so then I spent a really long time, my junior and senior years of college, shadowing tons of different people in different areas of healthcare and figuring out exactly what I wanted to do. I settled on going to PA school and then started the daunting task of applying to PA school. I gave myself 1 year to do any prerequisite work that I was going to do at a local community college close to home. And I ended up going to PA school at a small university in Virginia called Shenandoah University. I kind of dropped this in here, but some thoughts on applying to PA school, which is probably the most relevant slide to all of you in this presentation. But I actually think the program and the way PA school applications are set up is horrible and not to your advantage as an applicant at all. Every school has different requirements, unlike the medical school system in America. Every school has different dates and deadlines and start dates. And so you can hear from one school before one school has even looked at your application. And you could spend probably 5 years taking classes to make sure that you have the prerequisites completed for every PA school in the country. I don't recommend that by any measure. I do recommend kind of figuring out what your priorities are in a school. What are you looking for in an environment? What are you looking for in your school community? What are you looking for in terms of location and finances and blah, blah, blah. And going from there, seeing what prerequisites those schools require and what you have and don't have. I'm also of the firm belief that required patient care hours don't actually make you a better or worse PA or PA student. And I think they significantly decrease our diversity and access to PA school. That's not a common opinion, but it is mine and I stand by it. I personally did not have a lot of clinical hours before PA school. When I did my year of prerequisite work, I coached volleyball and I babysat because I made a lot more money babysitting in cash than I could as an hourly paid MA in an office. And that really helped when I went to PA school and had to pay for it. And so I think it's also important to know kind of what you need to do, that you do have to check that box, and what different schools require. Is scribing counting as clinical hours for a school? Can you volunteer? All of that stuff can be really important. But again, figuring out what your priorities are before you start the process of applying. I also added some thoughts on finding a job in here. I know that's later down the line for most of you, but I think really at the heart of it, this presentation is about understanding that a PA's role is different in every workplace. I have another PA in my office that works with a different surgeon, and our day-to-days look entirely different. And so it's all about creating what you want and finding what you want. But I think more importantly, on finding your first job in particular, is knowing what you like and don't like in healthcare. You cannot do a clinical rotation in every field of medicine, but you can work in pretty much every field of medicine. And so you have to take what you like and don't like about each rotation and apply that in different ways. Did you like procedural things? Did you like long-term care? Were you okay if your patients weren't getting better? I personally hated my emergency room rotation because I spent the next day of every shift looking up all of the charts of the patients I had admitted the night before to figure out what happened. The idea of treating somebody and then never seeing them again did not sit well with me. I also think it's important to know when you are doing your rotations and as you are doing your rotations, where you are and what laws are different there than where you work. That's usually more relevant on the East Coast because the states are so close together. Here in California, you can go a really long time before you leave California and hit different state laws from most places. But on the East Coast, there are things in like Virginia and Maryland that PAs have different regulations and rules on, things like delivering babies, et cetera, that may be really important to consider before you go into a specific field of medicine. And then also on your rotations, it's important to take away all the different ways in which PAs can be used, inpatient versus outpatient, one-on-one with a surgeon, or covering many surgeons, et cetera, and just paying attention to that. I think it's really important to find a good environment as a new grad. You want somebody or people around you who want to teach you. You will not know everything you need to know on day one, nor will you 2 years in or 5 years in, to be perfectly honest. But you want to make sure that you're finding an environment that you think will be supportive of you and a supervising physician or group of supervising physicians who will do the work of teaching you, because it is increased work for them to get the benefit of you in their practice at the end of the day, somewhere 6 months, 2 years, 5 years down the line. I urge everybody to spend a day shadowing before they accept a job. If an office is not willing to let you do this, you should be afraid. And don't accept your first job just to have a job. There is a need for PAs across the country. It has been difficult to find jobs for PAs during this pandemic, mostly because hospitals are cutting pay and letting people go as they're not getting reimbursed for any COVID-related care. But I urge you, you will find a job and you should find the right job, not the first job. Also, you should have a number in mind. You may not get that number. That may not be what you end up getting paid, but you should have something in mind so that you're not going into it blind. There are lots of good resources for that. A little bit more about me, how I ended up in hand surgery, more my thought process than anything, which I think is helpful to understand. As I went through PA school and then through all of my rotations, I knew I wanted to be surgical. I liked procedural work. And I knew I wanted to have follow-up on my patients. So trauma surgery, general surgery, where you see a patient for one problem, usually for a short period of time, and then they're gone forever. was not sitting well with me. I didn't like working in an urgent care or an emergency room for that same reason. You never see your patients again. So I kind of narrowed it down fairly randomly to dermatology, cardiothoracic surgery, and orthopedics. I interviewed all up and down Southern California as I knew this is where I wanted to be. And I probably had in-person interviews after phone conversations, et cetera, with about 10 practices. I think it's really important, just like when you're interviewing for PA school, the school is making everything sound as good as it possibly can, just like you're making everything about your application sound as good as it possibly can. Make those weaknesses strengths. The practices that you're applying for jobs are doing that too. Nothing is pretty and beautiful every day. Work is hard and will be hard. What does it look like on those hard days, and how does the office get through them? I think that's important to kind of at least have an honest conversation about. No one should tell you that everything is roses and butterflies. It's not. And I think, again, I found a doctor who I truly believed would spend the time to teach me and then want me to grow and be more and more independent over time. I think that was a sense more than anything. I think a lot of people told me the same thing and that they would do that. And it's just finding somebody you believe and think is actually telling the truth. I don't know how to help you on that one.
Hey, Spencer, real quick, if you don't mind.
Yeah.
So there were a few questions in the chat, if you are okay with answering those about your background real quick.
Absolutely.
Awesome. So the first one I saw, oh, and by the way, there's a lot of people supporting what you're saying and saying that it's very relatable and all sorts of good stuff like that. But so first question, Natalie Cardenas is asking, how much freedom does a surgical PA have, and what other surgical PA opportunity are there besides hand surgery?
There are surgical PAs in every surgical field that I can think of. Anesthesia would be the one that's a little bit different because there are CRNAs. How much freedom you have depends a lot on your setup. I was kind of going to go through my day-to-day, but I have as much freedom as I want in the office. I let patients leave without ever seeing the doctor over and over again all the time. I also have all the help I need when something doesn't make sense or I don't know what's going on or can't figure out why my treatment plan isn't working. There's always somebody here to help me, somebody that I trust and wants to be there for me. So I think that's important. In terms of operating freedom, that's a little bit different. You can't operate without a surgeon, and that all depends on what kind of surgery you're doing. Lots of general surgery PAs that work with robotic surgeons, you can't be manipulating the robot, but you are very involved in terms of changing instrumentation and moving arms and placing portals and stuff like that. I do a lot in the OR depending on the case. I think most surgery, particularly hand surgery and orthopedics and such, but really most surgery in general, takes more than two hands to do. So you would be surprised, especially when you know and can predict the next steps for a surgeon, how imperative you can be in the OR. I do think that changes some as you start being a PA that covers a whole group of surgeons. Again, I work one-to-one with a surgeon, so he operates without me only when I'm on vacation, really, which isn't often, unfortunately. But so I think that level of freedom in a surgical PA, most of your freedom comes in being in clinic. But in terms of where there are opportunities, I really, other than anesthesia, which isn't quite surgical, but they are in the OR, can't think of a field that I haven't seen or worked with or heard of a PA that works in.
Awesome. And we'll just do one more and we'll save the rest for later, just for the sake of time. But Nidal Al-Masari is asking, how many PCE hours did you have at the time of applying?
I don't have any idea anymore, but I had enough to apply to many schools. And I will tell you actually that nationally PCE hours are decreasing over time. When I applied to PA school, there were schools asking for like 3, 5, 7,000 hours, which is working full time for that many years essentially. And now it's closer to 1,000-ish as a general rule of thumb. I probably had about that many. I couldn't give you an exact hour, but I will tell you that most of my PCE hours were volunteering at a gang rehabilitation location doing laser tattoo removal, which is not anything anyone ever says that they do, but it was not in a typical healthcare office, but I was absolutely treating patients.
Awesome. That's a relief to hear for myself, and I'm sure a lot of people out there in the chat. But yeah, there's a few more questions, but we'll just aim for later. So keep going on as you please. All right.
Beautiful. My day today, and today really, involves me still being in the office at 7 p.m. But I work at a level 1 trauma center. We are a teaching hospital, which with our own orthopedic surgery residency. So we have orthopedic surgeon residents on the hand service all the time at different levels. So we have interns, 3rd years and 5th years usually. We also have plastic and reconstructive surgery residents on the service from an outside institution. They are 3s that spend 2 months at a time with us. Our office, 3 really surgeons take 100% of the hand call for our hospital. So we are a high volume, busy practice. And we treat anything that comes into the emergency room hand related. I spend about 50% of my time in clinic and 50% in the OR. COVID clearly has changed that a little bit. Elective surgery ended for a time and we decreased our patient volume significantly in the office, but we're pretty much back up to our pre-COVID volumes now, with a little more virtual visiting and such like that. I take no call, which is really just luck. From a surgical PA standpoint, that's pretty unheard of. And my rule for myself, which is probably not great, in all honesty, you should create better boundaries than this, that once I leave, I don't come back. I will not come back in the middle of the night. If there's a case going on, I will not come back to make sure things are okay. But if stuff comes in while I'm still here, I will at the very least stay to make sure that the case is set up properly or to get it started. Usually I stay until it's done. That means that if I thought I was leaving at 3 and somebody cut 4 fingers off, that I can easily be here till 3 a.m. But I don't come back once I leave. And I do get my weekends to myself mostly. I do have my own clinic panel of patients. It's usually about, 18 to 35-ish a day. Anything from new patients, consults, emergency room follow-ups, to our own patients that we've been seeing for some time and post-op patients. Especially when I started as a new grad who didn't know anything about hands. I did try and see all of the new consults on my supervising physician's schedule. That has continued, actually. I think I learned the most from it. Patients don't love it, but sometimes it's a fun game to see if you can make them love you more than they love the doctor they're seeing. And that has pretty much continued. I don't let that get in the way of my own patient schedule, so I won't get behind, so I can see his new patients. But I try to. I think I learned a lot from it. And I think it makes patients trust me so that if we end up operating on them later, they're not uncomfortable in their post-op care because they're seeing me and not him. I also think that's important because one thing I hated when I was a student was making presentations about silly stuff that I thought was irrelevant, which is important when you are learning. And I ended up saying, I thought I would never do it as a professional, as a licensed PA, but I do. I spend a lot of my time giving presentations. Now they're a lot like, hey, this person has X, we're gonna do Y and Z. I already ordered it, come say hi. But when I first started, it was a lot of this is what I'm finding, this is what I'm thinking, and much more academic than they are now. All of that to say, the formal presentations you are forced to make in PA school and as a student are relevant, but do change as you kind of work and go on in your career. My last fun note is that charting sucks, stinks, always. It always will. It's a skill. Nothing looks like the soap notes you write in PA school. And it takes a long time. So it's a skill you should work on a lot, especially as a new provider. Disclosures, not really relevant, but I don't represent the hospital I work for or the practice that I work for. I'm just me. A few cases, lots of acronyms. We'll go through them a little slowly, and we can kind of think through this. A 35-year-old man brought in by ambulance after a motorcycle crash. Right hand dominant, otherwise healthy. He works as a laborer. And hand surgery, hand dominance, and occupation are particularly important because people's functional needs are different in their dominant hand versus non-dominant hand, as well as if they sit at a desk and type all day versus lift 50-pound cement bags all day, every day. Vital signs were stable. He complained of right wrist pain and left knee pain. I'm going to give you the answer on the left knee. He had a tibial plateau fracture that was taken care of by a different orthopedics team. I'm also going to tell you that in hand surgery, so long as vital signs are stable, that's really most of what you care about in terms of somebody's general exam, because we are doing very focused exams overall. But for his right arm, he had good motion and no pain at his shoulder and elbow. He had wrist and finger motion that was limited by pain. He could move everything to the best of our ability to tell until he said, ow, too much. And he had paresthesias, or funny feeling, in his thumb, index finger, and middle finger, as well as pain with passive extension of his fingers. So if you tried to push his fingers, it was very, very painful to him. The next step for us is x-rays and a shorter physical exam. His skin was overall intact, no open fractures, nothing like that. He could flex and extend all the joints of his fingers actively with some pain. He could make a thumbs up an okay. He could cross the second and third digits of pain. These are kind of the cornerstones of a hand surgery exam, mostly because those three motions test all of the nerves that supply the muscles of your hands. And these were his x-rays on the left. He has a dorsally displaced distal radius fracture. You can see it goes right across there. It's a little bit smashed down. This corner belongs up here. I don't know if you guys can see my arrow, but, and I only gave you 2 views. You should always look at more than 2 views, at least more than 1 view, but there's no evidence of any further dislocation or fracture. Overall, these x-rays look pretty good. He does have perhaps a little ulnar styloid fracture there. So his diagnosis is a right displaced comminuted intra-articular distal radius fracture, i.e. he broke his wrist. It's not in the correct alignment. The fracture goes into the joint and is in more than 2 pieces. There are about 3, maybe 4 there that I can see on x-ray, as well as acute carpal tunnel syndrome. That numbness and tingling in his hands happens from bleeding from the fracture into the carpal tunnel, which puts pressure on the nerve. And so the plan for him was attempt a closed reduction in the emergency room and splint him in whatever position we got him in. Acute carpal tunnel can be a surgical indication in and of itself if it doesn't improve, though paresthesias are really hard to interpret when you in the setting of kind of immense trauma like that, because nothing feels normal. So ordinarily we plan for strict elevation overnight and close observation, and we make almost everybody that stays in the hospital NPO at midnight, nothing by mouth after midnight, for fixation of his right wrist, open reduction internal fixation. 2 hours later, the resident on call had gotten a call for more pain medication to be ordered from the nurse. That in and of itself should warrant an exam by somebody. Patients who have pain med orders that seem reasonable should be re-examined if their pain medication that's ordered is not covering their pain without a change in situation. Obviously, if you take someone to surgery or they've done physical therapy or something changes, you can evaluate that. But for the most part, if patients' pain medication needs are changing without a change in their clinical status, you should be asking why. And so this patient got examined again. He had increasing numbness and tingling to his fingers. He had increasing swelling as well as pain and narcotic need. He started to have clawing of his fingers, couldn't extend them anymore, more pain when we extended his fingers. And that thing you hear or will hear in PA school all the time, pain out of proportion to exam, i.e. it hurts more than we expect it to. This is something that's really hard to teach and really easy to appreciate clinically once you've seen, 3 of something. That pain out of proportion, you'll figure out eventually, I promise. Our first treatment plan for this guy would be to take his splint off. We took a broken wrist, we wrapped it in something tight to try and maintain alignment, and that may be making things worse. So we cut the splint down. We're planning to take him to surgery anyway. And it doesn't get better when you take the splint down. That feeling of pain out of proportion to the exam should mean something to you. So now he has a right distal radius fracture, an acute carpal tunnel syndrome, and compartment syndrome, which is a surgical emergency that is increased pressure in the muscular compartments of usually an extremity. And for that, he goes directly to the operating room for fasciotomies, i.e. we cut the layers of fascia between the muscles so that we can release them. At this point, this guy has signed himself up for at least a 2-stage surgery, possibly a 3-stage surgery. When you do fasciotomies, you are releasing pressure, and saving muscle. Time is muscle in this event. Sometimes you can perform the fixation, you can fix the wrist at the same time, depending on how the muscle looks. Sometimes you can't. And either way, these people end up with big open incisions because their muscles just expand as soon as you release the fascia. And so they need, if not subsequent surgery for fixation of whatever the trauma was, they generally need to go back to the operating room for wound closure, skin grafting. This guy ended up getting fixation at the time of his fasciotomies, and he went back 3 times, I think, for wound care, debridement, and then for closure with skin grafting. Some thoughts. Compartment syndrome is a surgical emergency. It leads to muscle death and thus dysfunction of the extremity. Most things in hand surgery are not surgical emergencies, and we do a lot of great, we will see you tomorrow morning and we will take care of it, and not a lot of, oh my gosh, I'm going to drive in from home at 3 a.m. to take care of this. But you really can feel it from the entryway of the room. That's a lot of that pain out of proportion to exam. You know that patients are just way more uncomfortable than they should be with a wrist fracture because of their compartment syndrome. I think this case and compartment syndrome in general talks to how important a physical exam is. Your fractures will always show up on x-ray, but compartment syndrome never will. You can't see it on x-ray, so you have to examine your patient. I also think the other point that this case brings home is that your first exam is not your last exam. You have to know when you need to watch people closely and how closely you need to watch them, and when something outside of what you're thinking should warrant a second exam. Increasing narcotic need should always be one of those things. I think the other important thing to know here is, as a new graduate PA, as a trainee, as a student, as an observer, all you need to know in that situation is that something's not right. The patient shouldn't be having increasing pain overnight if you're treating it appropriately. You don't have to know that the answer is fasciotomies. You don't have to know that the answer is compartment syndrome. You don't have to know that that's a surgical emergency. You do have to know that you need to go get somebody or talk to somebody about it, and that something is not right. Are there any questions I can answer about that case?
While we wait for those questions to pour in about that, do you mind if I ask one myself?
No, absolutely.
Okay, perfect. So I was just wondering, I know a lot of your cases are bone related, and even though this one was more a muscular skeletal thing, how often do you see like osteoporotic, like decay or something like that coming into play?
So osteoporosis comes into play mostly in terms of severity of fracture. Generally, trauma, falls, and stuff are what cause the fracture themselves, and they just fall into pieces. I like to call them cornflakes when the bone has less density. I do see a fair amount of bone decay from osteomyelitis, infection of bone. One of the very first patients I saw on my own in clinic had both of his forearm bones exposed through a wound that hadn't closed over 3 years. And healthy bone looks kind of like you would expect, white, shiny, healthy, and his bone through his arm looked like dead coral that you see on the beach. You don't really see kind of bone decay like that from osteoporosis. That's usually from infection or something like that. But we do have elderly people in general tend to have osteoporosis, and it plays a role in how we fix them. It plays a role in how severe their fractures are. It doesn't really play a role in who has problems and who doesn't have problems.
I see. Wow, that's gruesome. Just that image. But thank you for answering that. I was just wondering because generally when I think of like osteoporosis, I think of like the femur or like spine or something, but I feel like it should come and play with the hand, like you said.
It definitely does. And I will tell you that more people than you want look at their x-rays and want you to say how osteoporotic they are. And it's not really something you can determine based on a wrist x-ray. There's very specific x-rays that give you osteoporosis scores. And it is lumbar, spine, hip, things like that. But you can feel it when you're fixing bones, and how much resistance somebody's bone gives you tells you a lot about it. So there are some people who we fix and then we say, hey, you need to pay attention to this or you need to go be tested.
Awesome. And there were a couple questions from the chat. Jessica Tokars wants to know, she said, wow, that's a very interesting case. How often do you see something like that?
We see compartments probably monthly, in all reality. Sometimes you catch it early enough and can just open the skin and the superficial fascia, though I would tell you that's not the standard of care. You should open the deep fascia always. But, being a level 1 trauma center, we have a lot of patients that have high energy injuries, which is one of the risk factors for developing compartment syndrome. And I would say we see it monthly.
Awesome. And then Jasvir Abwan, asking a little bit of a physiological question, wants to know what is the cause of the increased pressure of the compartment syndrome from the time of x-ray to 2 hours later?
It's the swelling of the muscle. So probably a reduction at that time didn't help us. Pulling on a broken bone is lovely and oftentimes can help patients avoid surgery. But when you have a extremity that has suffered trauma and then you manipulate it more, you're increasing the inflammatory response to the area. And so the actual swelling of the muscle is what increases the pressure.
Awesome. Okay, thank you so
Thank
much.
you.
Yeah, so that's all the questions for case 1. You can move on whenever you're ready.
Beautiful. So our second patient is a 28-year-old female, also right hand dominant. She's a musician. FYI, in hand surgery, we treat musicians, painters, things like that a little bit differently than the general population, just because there are some things that they have to do differently. She has a 6-week history of left wrist pain with certain motions that began after a fall while skateboarding. On the day of the fall, this is all well before I saw her, she went to urgent care. She had some radial-sided, thumb-sided wrist pain and a little bit of swelling with some bruising. Her x-rays were read as normal per the patient at the urgent care. She was told she had a likely sprain and she was given a removable splint and told to follow up with her primary care doctor in 2 weeks. About 2.5 weeks later, she saw her primary care doctor. Her exam was benign per the primary care doctor, and she was instructed to take the splint off and resume her activities. When I say her exam was benign, the primary care documented that her swelling has resolved, that she didn't have any pain or tenderness at the wrist. They did not repeat x-rays at that visit, but the primary care doctor did look at the report from the urgent care x-rays that said no fracture. And so she was instructed to take her splint off more and more, wean it, to resume her activities. And then again, this was a likely sprain. 4 weeks after that, 6 weeks after her initial injury, she presented to my office with continued pain with activities. She was an otherwise healthy young female and no distress. Her skin was clean and dry. She didn't have any swelling or bruising by the time I saw her. She had great motion of her fingers, shoulder, and elbow, but she did have pain with thumb extension. She also had pain with wrist flexion and extension, as well as radial deviation of her wrist, especially. She had no ulnar-sided pain or tenderness to palpation, no tenderness to palpation in her first dorsal compartment, which is these tendons that make your thumb abduct over here. But she did have tenderness right at the radial styloid, the tip of the radius there, the snuff box, which is the soft spot at the base of your thumb, and the volar tubercle scaphoid, which is over here. Your differential at this point is something to think about. She could have had a non-displaced fracture of her distal radius. She could have torn some of the wrist ligaments. She could have done nothing and really just had a wrist sprain, though most people should be at least getting better by 6 weeks with proper treatment of most injuries. So what are your next steps? In my office, your next steps are to repeat the x-rays. And I'm going to take you through these x-rays kind of slowly right now. X-rays are fun. They can tell you a lot of information. They also don't tell you a lot of information, and it's very easy to miss things. So I think the important things to know when you look at x-rays are to look at the not obvious things first. So you really do want to trace all of the bones all the way along and see that there is kind of smooth cortex all the way around. And these x-rays, I see that in all of the bones. You want to look at all of the joints. You can do that best on this view over here on the right. In these x-rays, you can see that the joint spaces are all pretty symmetric and normal. You can see on the lateral that everything is in line. Again, you have to look at 10,000 normal x-rays to figure out which ones are abnormal, but over time you do learn these things. And to my eyes, these x-rays look beautiful. I don't see anything wrong either. But again, someone should not have pain for 6 weeks without getting better, particularly after a fall. So then you ask yourself questions like, should I get a picture of the other side so that I compare it? Should I get stress views? Should I make sure that I can look at the old x-rays from urgent care, which I don't have access to in my health record, to be able to make a determination? For this sort of injury where somebody is point tender in a very specific region over a very specific bone, I'll give you a hint, it's the scaphoid. I don't need any of those things. The other side isn't going to tell me anything, and what the x-rays looked like 6 weeks ago isn't going to tell me much because right now they still look fantastic. So snuff box tenderness, volar tubercle tenderness in my hands is a scaphoid fracture until proven otherwise, and therefore the patient gets a thumb spica splint. This is a splint that takes away your thumb, leaves your fingers free, and goes down to your forearm. It is very inconvenient, and you have to have a conversation with the patient about how much risk they're willing to accept, because almost no patient will want to be in a fiberglass cast while you figure out if or if not they have a fracture. So then you talk about something removable. How much do you trust the patient? Are they going to keep it on? What happens if there really is a fracture and you've given them something removable and they are not the most responsible patient? I think this is when understanding your patient and knowing how much risk you're willing to accept and they're willing to accept and how convinced you are by their exam makes a difference. This person got a plaster splint, something they couldn't take off. We made sure that her fingers were free so she could continue playing the piano. And you get further imaging. A scaphoid fracture will likely be seen on CT or MRI given different things. We think of CT as better for bony detail and an MRI as better for soft tissue. I will tell you that CTs, particularly of the scaphoid, which sits outside of the plane of the hand, it goes from here to here and doesn't lie in line with the hand, can miss non-displaced scaphoid fractures. And at this point, I'm pretty sure that this is non-displaced because I have x-rays and I can't see a fracture. An MRI won't show me the bony detail as well, but will show me the reaction of the bone. So any bone marrow edema, any changes in the bone that signify a fracture, it may not show me exactly what that fracture fragment looks like, but it will show me that something's happened. So it's more sensitive for a non-displaced fracture. I'm also going to tell you that if I were planning on operating on this person, if I knew there was a fracture and I was trying to plan surgery, I needed to understand the fracture better, that patient gets a CT every time. So this person got a splint in my office, got sent for an MRI, and was determined to have a non-displaced scaphoid fracture. Scaphoid fractures are special because they, one, are the most commonly missed fracture on X-ray. In the emergency room and urgent care setting and primary care setting, I believe about 25% of them are missed on X-ray. They're also special because the scaphoid gets its blood supply backwards, and therefore it takes about twice as long as the average bone to heal. Patients get full-time immobilization and a thumb spica something, splint, cast, whatever. You decide based on your assessment of the patient and their ability and kind of overall workload for 6 weeks. We do have a 3D printed option that allows people to sweat and get wet now for these injuries in particular, particularly those that we operate on, which get immobilized for 12 weeks. And that splinting can continue until you have scaphoid healing. I've seen somebody be in a splint for 6 months for a scaphoid fracture. Most people who are immobilized for anything over 3 weeks other than kids, really end up needing therapy as stiffness becomes a problem. And people tend to get their splints off and think that that means they're healed and back to new. They may be, their bones may be healed at that point, but they haven't used their hand normally for a long time. So there's significant weakness you have to work through. So scaphoid fractures are the most commonly missed fracture. There is a risk of avascular necrosis, i.e. bone death by way of not getting blood. And so it's important to recognize them, even when you can't see them on x-ray, but the clinical symptoms and what you're seeing clinically, and trust your gut on that. It's also really important to follow up with patients. If you see a patient in an urgent care setting and you're suspecting something, call the primary care doctor and say, hey, I'm worried about this patient. I saw them, I saw this, I got x-rays, they were normal, but maybe the patient would have avoided a primary care visit and seen hand surgery right away, which probably would have saved her that 4 weeks of pain. I would have loved if the urgent care provider had called me directly, or if the primary care doctor had said, hey, I saw this girl, it's been 2 weeks, she's not better, she's still in a thumb spica splint, when would you want to see her? It would have been probably about a week later, not 4 weeks later. The world's not perfect, she wasn't harmed, but these are the things you want to do to be an exceptional provider. And I think the most important thing about this case is that patients should get better. At least young, healthy patients with hand injuries should get better. No one should have pain that's not improving over 6 weeks, particularly after a trauma without some explanation for it. Arthritis isn't going to get better, things like that, but most things should be getting better. Any questions about that case?
Yeah, so there were actually quite a few. Mia Kraut wants to know, why is the scaphoid fracture generally the most missed?
Because the scaphoid doesn't lay in the plane of the hand, so we don't have a good way to get x-rays of it to look at multiple views. It's sort of like S-shaped like this, and it goes from volar to dorsal, so we don't have a good way to take pictures of it.
Awesome. And then Melanie wants to know, as a new grad, did you practice reading x-rays, or did you get better at that, like on the job?
Both. When I first started, I would go through the clinic schedule and read every single x-ray of any patient that was seen in my entire office. That's 5 hand surgeons. When I got home at night, and then I would go back to their notes the next day and make sure that what I saw agreed with what was there. I don't do that anymore. It's a waste of time now, but you will miss things. There will be things that you don't understand. There will be things that you don't catch, and you only learn by going through it. So I did practice. It's not like somebody gave me a book and said, here, study these. This is what you need to know. But I had plenty of real life examples all day, every day, with built-in answers in terms of the doctor's notes documenting them. I also asked very specifically my supervising physician when I first started to show me any interesting x-rays. So we would go over a lot of more complicated ones or things that just weren't as common pretty regularly. My biggest tip for new grads is that when you start in practice and are reviewing imaging with the patient, review the images before you go into the patient room. Ideally the night before, but that's not always possible. We take all of our x-rays in our own office. They're not done the night before, so I couldn't look at them the night before. But make sure you have an understanding of what's going on in the x-ray before you go in to talk to the patient. That's 90% helpful. I will tell you that sometimes it's really helpful for the patient to say, look, I have pain right here. And you can look at an x-ray that probably you would have read as normal previously, and you can see a fracture there. You can see on my Instagram, actually, there's a great case of a really young person, I think she's like 18 months, something like that, with a wrist fracture that I totally missed. And the patient was not harmed, and she's totally fine now, but it happens. You won't be the first, you won't be the last, and it does take practice to read x-rays over time.
That's amazing. Thank you. And that was really good advice. Let's see. Jasmine would like to know, can breaking a bone ever lead to arthritis in the future?
So the trauma, the injury itself, increases your risk of arthritis at baseline. Just having the injury does. If that fracture changes the joint articulation and you leave it like that, which we do sometimes in wrists. Little old ladies, we don't fix their wrists very often because they can tolerate it just fine. You increase the risk of developing arthritis from that baseline increase. And the longer the joint stays malaligned, the more significantly that risk is increased. Fixing that bony alignment will not take away their increased risk from the injury. It can decrease the risk from what it would have been if you kept the joint alignment off, if that makes sense.
Awesome, thank you. And then we'll just do one more on that case. Somebody was asking about, I know you mentioned the adherence with like the brace or the splint where they can take off versus the plaster one. So they wanted to know, like, how do you ensure you can follow up with your patients, make sure they're doing what they need to do if they do have that option?
So you can't control everybody. But for the most part, somebody who's having pain in their wrist, who's coming in 6 weeks later to say, hey, why am I still having pain? They're going to come back. And while you don't necessarily know if you give them a removable splint, how much they're wearing it or not, oftentimes they'll tell you. They'll say things like, I'm not supposed to tell you this, but I really didn't wear my splint. Oftentimes you can tell by somebody's personality if they're going to do it. This person in particular told me she wanted to be able to play the piano. Okay, the safest way I can do that is put you in a fiberglass cast that you can't get off really without a cast saw, and let you play. That way I know you're safe and I'm not really taking what you really want to do away from you. That's not always possible. Sometimes you can't let people do what they want to do. But we have pretty good follow-up. There are always going to be people who come in, want a diagnosis, and never come back. You can't do anything about that, and you can't guarantee anything really. But we do the best we can to have the patients understand the severity, particularly with scaphoid fractures, because it can cause really significant problems if they don't heal.
See, it's too bad you can't just go break down their door at home and then make sure they're wearing their brace, right?
Sometimes I wish I had little GPS trackers on the splints. But
Yeah, that'd be nice.
Yeah.
But most of the other questions are kind of general, so we'll just save them for the end if that's okay with you.
Totally. Okay, so obviously my practice is not all the most commonly missed fracture in the world and the only surgical emergency in hand surgery. I would say in clinic, I see about 20% shoulder patients, 20% elbow patients, 60% hand patients. The most surprising thing to me about my role in hand surgery is that I see a lot more medicine than I thought I would. You'd think that upper extremity surgery has nothing to do with the general medicine side of things, but gout and pseudo-gout have significant roles in joint arthropathy and things like that. Diabetes, cancer patients have a lot of peripheral neuropathy that comes up in terms of numbness and tingling in their hands. Kidney patients end up with lots of different kinds of masses in their hands from their hypophosphatemia. HIV patients, again, have a lot of numbness and tingling from their antiretrovirals. Rheumatoid arthritis has that classic degeneration of the hand, and you get the ulnar deviation of all of the fingers. Psoriatic arthritis is often expressed in the hands. Crest syndrome is cutaneous calcinosis of the fingertips. So that has been fun for me. I probably still wouldn't pass my pants right now, having not studied or done much general medicine in the last 3 years, but it does keep you thinking and on your toes and having really good relationships with primary care doctors, which is great. I do have actually more long-term and chronic patients and problems than I expected. There are people that have arthritis forever and ever and ever and just need continued injections or pain relief or eventually surgery or convincing that maybe they don't need surgery. We see a ton of trauma, falls, knives. Don't cut avocados in your hand, please. Bagels, mandolin injuries, particularly now that it's Thanksgiving time and people are cooking. Also, particularly when everyone went home because of COVID and decided that they should cook more. Don't cook if you don't cook. Fingers and doors, drawers, all of those things. And then some insidious conditions, tennis elbow, things like that. Wrist pain that's been going on for 2 years, blah, blah, blah. I listed you some of my most common diagnoses. These slides are pretty wordy just so you can have the information. I'm not going to go through all of those unless somebody has a question about it. My surgical practice is pretty different than my clinical practice. We probably do about 5% of our surgical work is on the shoulder, 5% on the elbow, and 90% on the hands. I think it's really important from a surgery side to make friends with referring providers, whether it's the rheumatologist, the primary care doctor, the pain management doctor. You don't want to be the person after surgery managing somebody's primary care problems. You want the rest of the team to do that. But if you don't talk to them about having surgery, somebody having surgery, they're not going to be there for you to manage their problems afterwards. Obviously, trauma is our main source of surgeries. People fall and have broken bones, they need to be fixed, etc. I think one of the lovely things about hand surgery is there are not a lot of emergent things, nothing that has to go tonight to now, minutes ago before the patient even got in. There are a few. Most things are urgent at best, even when people totally cut their fingers off, that can wait hours. We don't like to, but it can. Some things can wait months, some things days, some things minutes, and understanding that difference is important. It helps in terms of planning and what your week and day is going to look like. It also helps in terms of how you counsel patients. Somebody breaks a bone and they're going to their grandmother's funeral tomorrow. They don't have to have surgery tomorrow. They can have surgery next week, and the outcome is going to be no different. I do work with residents. They are in the OR with us. Sometimes that can be challenging. Sometimes it's great. It does mean I do a lot less hospital floor work than I would have to do if they didn't exist. And I don't have to take calls. So I am grateful for them. Somebody asked about freedom in the OR. I would say my involvement in any case depends on exactly what the case is. The routine cases that we do all the time, my supervising physician and I could probably do mostly with our eyes closed and without any words being said, because we know the next step for each of us are. The cases that we don't do all the time are obviously not like that. I would also say my tip to anybody that's in an OR ever, whether you're observing, whether you are a student, whether you are the attending physician, is that the scrub techs and circulating nurses are your best friends. Make them your friends, keep them your friends, make them love you, make them need you. And again, the kind of common things that we operate on, mostly nerve and tendon repairs after lacerations, whether it's knives, blades, saws, etc., etc. Some random thoughts. I think, again, my biggest take-home message on being a PA is that it can be really whatever you want it to be, or whatever somebody else wants it to be for them. So make sure you know what you want and you get what you want. You can find it. Know what you're looking for. Know why you're doing what you're doing, and especially what you want out of it. PA school's hard. It is worth it. I wouldn't want to do it again, but I'm glad I did it. I do think it's important to set expectations with your friends, family, loved ones, so that they understand that this 2 to 3 years is going to be challenging. Work-life balance, I think, is a fallacy of everyone's imaginations. I think, as Ruth Bader Ginsburg said, you can have it all, just not at the same time. I work a ton right now. Again, I don't leave if there's stuff going on here that I know is here. And I learn a lot from it. And so for now, I don't have kids and that's what I get to do. That will likely change at some point. And then I think we talk a lot in the PA school application cycle and in talking about our profession about flexibility. And I think what I have found professionally is that most people do not change specialties, or at least don't go from being surgical PAs to primary care PAs or inpatient cardiology PAs. You find the job you like because that's what you like doing, and so you stick with it. I also can't imagine starting over in any field right now. There are lots of things that I know about hand surgery now, and I can very confidently treat on my own, and I can't imagine being essentially a new grad again. And while my license would allow that, that's not what I want. But I do think there is a lot of flexibility in terms of what your practice looked like, and what your relationship with your supervising physician or physicians is, and what your role is. And I think that's the part of the flexibility of being a PA that we don't talk about as much, but probably is more relevant to our day today. If you are not asleep like my boss is in this picture, given that it's so late, I'm happy to answer any questions that you guys have.
Awesome. I was wondering who that was.
That's my boss.
So that's what the supervising physician does while you do all of this stuff. Okay, got it. If it's okay with you, I'll just copy and paste some of the questions that I recorded into the chat in Zoom. That way you can kind of pick and choose whichever ones you want to answer. I don't want to keep you here all night, so that way you're not answering all of them.
Beautiful.
Okay, let's see.
I don't pay my supervising physician to review my charts. I think that's part of his salary and the extra financial benefit of having a PA. Also, our hospital system has a 5% rule. So every month, 5% of my charts have to be signed. I will tell you that he doesn't sign any of my clinic charts. That's not where that comes from. It comes from discharge summaries, admission orders, and what we call a pre-op attestation, which is just a note that has to be filed preoperatively that absolutely has to be signed by the surgeon themselves. And so I write them all. He signs them all, and there's my 5% of my cosigned charts. It doesn't actually review generally anything like that. Somebody said, is this in every specialty? Could you talk about this more, please? Oh, that's the same question. Okay. So yeah, no, I don't actually know anybody that pays their supervising physician to review charts. That would surprise me. I would, as a PA, not have a job for that had that requirement. I would say that's crap. Don't treat me like that. If you're not willing to review my charts that X, Y, or Z, be it the government, the hospital system, the practice is making you review without me paying you, then I'm not going to work for you. How did I meet my supervising physician? Luck. I graduated from PA school in December. I passed my boards in January. I don't know if you guys know this, but the PANCE is not offered for 2 weeks around Christmas time. So I took them the first day I was eligible to after the new year, and it opened again, and passed. I started applying for jobs kind of fairly peripherally. I lived in England for a few months with my boyfriend who was playing professional hockey over there. And then I came home and started actually applying to jobs more seriously. The job I currently have is one that I randomly sent a resume to in that January, February time. And they called me in July, well, maybe June, and said, hey, we're interested in you. So I came in and I interviewed with 9 people in the office, every single doctor, and my supervisor was the last person I met. And I believed what he told me about wanting me to learn, wanting me to be different 6 months from when that was and 2 years from when that was. But the person who really sold me on the job, who not guaranteed, but who made me really feel like I could believe what he was saying, was the other PA in the office. So I think for me, I was fortunate to have the balance of being the doctor I worked with first PA. So a lot of what I did, I could build myself. I could make it how I wanted because he didn't have a way of doing it before. But also in an office that had PAs, so our front office knew how to talk about seeing a PA instead of the doctor, and what I could and couldn't do. So that wasn't all. I didn't have to do all that teaching on my own. I think my biggest tip for finding a physician to work with is trusting your gut. Interview with them in person. That's a little bit harder than it usually is right now, given the pandemic going on outside. But you should meet them in person. You should feel like they're listening to you. They should want you to interview them just as much as they're interviewing you. You should be scared if they're not willing to answer your questions or avoid your questions, and trust your gut. Know what you think you need in a supervising position. For some people, that's somebody that's going to be pretty standoffish and let you work through things on your own. That wasn't me. I wanted supportive. I wanted somebody who I could call at 3 o'clock in the morning when I was still thinking about the case from the day. And I think I can do that. I don't, but I think I could. I think residents are a tough thing. And I think the most important thing, the question is, when considering a surgery specialty, do you think it's important to consider if residents are there to ensure most time in the OR as a PA? I think a lot of it depends on what you are looking for in terms of if you want to be operating a lot of the time. Teaching residents is important to most attendings who work with the residency program. And so you will lose out on some operating opportunities because of residents. At the same time, once you've established a relationship with somebody, you can do and create the environment in the operating room that supervising physician or surgeon wants better than the resident who's been on the service for 3 weeks. And so there's a balance of that. Do I think it's important? I always thought I wouldn't take a job where there were residents, but I actually think having residents has worked in my favor, not only because I don't have to round on patients or see them on the floor or take call, but also because it means that the attending you're working with is willing to teach and has experience teaching. And as a new grad PA in any job, teaching is a skill, particularly surgical teaching. And it's, I think, and I feared, really easy to take on a position and have somebody train you for 2 months and end up being the same, at least from a surgical skill standpoint, the same PA you are at 2 months, where you can retract and do things pretty effectively, but not really do operational things as you are at 2 years. And if you have somebody who's not used to teaching, that would be a fear of mine. And so I think it's a balance. You have to weigh exactly what you're looking for, what you need. Are PAs allowed to make a first cut during surgery? This is usually a hospital or healthcare system based law. I actually don't even know what the state law is in California, but I'm pretty sure I could. Here in my hospital system, the physician has to do the timeout, i.e. the surgical pause before we start surgery, but I often make the first cut while the doctor I work with is scrubbing in, talking to the last patient, comes in and does a pause, we get started, and then go from there. And so that, again, how much you can do on your own is really mostly limited by healthcare systems at this time. I would be a little hesitant to say across the country because the laws do differ state by state. But here in California, as long as my supervising physician is available, I can do anything he tells me that I can do. Somebody asked if I got into PA school the first time I applied, and I said yes. I did get into PA school the first time I applied. I also was really particular about what I was looking for. I did not want to go to school in Southern California. I knew that being with my family and where I grew up was going to be too distracting to me, but that I wanted to work in Southern California, and therefore I wanted to be able to do at least some of my rotations in Southern California. And while that's easier said than done, you have to go to a program that allows you to do away rotations that you set up on your own if that's what you want. And so that's what I did. As a hand surgery PA, are you able to be on call at my place of work? Yeah. If I told them I wanted to be on call, the residents would love if I took phone calls overnight and they didn't have to. Sounds terrible. I couldn't be necessarily like on call in terms of being the surgeon that came in if there was a compartment syndrome, because here in my hospital system, the surgeon has to come in to do the timeout. So it would be silly for me to come in for the surgeon to also have to come in the middle of the night. And I like my sleep, so I don't have to. But yes, there's nothing legally there's no reason I couldn't take call. I'm just fortunate enough that I don't have to. Does becoming a surgical PA require more school or training compared to other specialties? No, there are some PA residencies. The other PA in my office did do a surgical residency after PA school. I did not. I think that's actually been beneficial to me because the surgeon that I work with can train me to do things exactly like he does, and I don't have bad habits or just different habits from somebody else. In school on your rotations, you'll find that every doctor does things a little bit differently, which is really what we want for them. But it's hard to unlearn what the last person told you to learn and do it somebody else's way. So you can do extra training, but you don't need it. There are PA school residencies or PA residencies in things like emergencies medicine, surgery. There's one in orthopedic surgery actually in California, but there's no hand surgery PA school fellowship. Do you tend to see the same type of cases as a hand surgery PA? So yes and no. We see a lot of very benign things, carpal tunnel, trigger fingers, tendonitis of the hand and wrist, but there's always something new every day. I don't know, food processor blades can end up cutting somebody anywhere, and there are funky nerve injuries that can happen and things like that. I think in any field of medicine, it gets repetitive, just like in primary care, you're managing a lot of diabetes and hypertension, and it's figuring out what you could do over and over again and not be bored by, while also being excited about the interesting things. Do PAs?
Thanks so much for doing this, Spencer. Just real quick, I wanted to let you know how much we appreciate it. If you don't mind, can I ask you one question?
Yeah, absolutely.
So we talked about this earlier, but I just wanted to ask about the background. Like, where are you? You're obviously not at your house, and you look like you're wearing scrubs. So just to reiterate.
I'm in an exam room in my office. You can see we have cool art on the walls. That's a light box for x-rays behind me. We have all digital x-rays now, but I'm still at the office. I was telling you guys before we started, actually, in Southern California, in the greater Los Angeles area, on the first Wednesday of every month, we have a citywide hand conference that was going on right before this, which is why we started on the later side. But I work a lot. I'm here late often. This is not entirely unheard of, and it's not just tonight, but yeah, I'm here in the office still in my scrubs. I did take my shoes off.
Yeah, the reason I wanted to make sure that everybody knew that is because you're technically not done with work. You stayed at the office just so that you could do this presentation.
Yes, I'm still here and happily talking to all of you. So
we really appreciate it.
Thank you so much.
Yeah, absolutely. We've had about average 150 viewers throughout this whole thing. So please know that this isn't a waste of your time. Like, you're definitely reaching out to a lot of people. So much support from the chat. Everybody loves what you're saying. They had so many questions for you. A lot of people like the late time because, you know, they're getting off of work, and that's kind of what we're trying to do, sessions at different time to reach out to the most people, a lot of people, you know. Please, guys, be sure to take a moment to follow her on Instagram. We'll relink her Instagram on there, and we also shared your email just in case there were any other questions that didn't get answered, or if somebody wants to reach out to you personally, if that's okay with you.
The only other, I'm going to answer a few more questions just because they're repeated ones. Somebody asked about why I wouldn't choose this field again. I wouldn't go to PA school again. I just wouldn't want to do PA school again because it's hard. I love what I do. I would do it again 100 times over. But if you told me I could avoid going to PA school again and still have what I have, I would. It's not that I wouldn't choose this field again. And then the other one is about charting and how much work I bring home. Are there days when I feel burnt out, and how much vacation time I get? How much vacation time a PA gets is very dependent on their practice and their goals and their role in an office. I get the same amount of vacation that every other provider in my office and healthcare system does. It's about 2 weeks when you first start and increases from there every year. How do I not get burnt out? I love what I do. I do bring a lot of work home in terms of charting and stuff. I'm getting better at it. And I don't get burned out because I work with people that make me happy. But those are really the ones that were hit over and over again. Please feel free to send me an email or shoot me a message on Instagram. I will get back to you perhaps in a delayed fashion, but I will get back to you, I promise.
This was incredible. Thank you so much. The thank yous are also flooding in on YouTube, and we're all super appreciative that you took the time to do this with us. Everybody learned a lot and everybody loved you, so thank you once again.
Of course. Have a good night, you guys, and feel free to reach out with any questions.
Absolutely. And so just to give you an idea, I know you can go back and look at the chat so that you can see exactly what was in there. But yeah, we have about 1 million thank yous. We have very informative. You're so intelligent. You're awesome. Thank you for being blunt. So much, a lot of good support. So we're like, you're definitely a fan favorite here. We really appreciate you doing this.
Well, have a good night, you guys. Be safe, okay?
All right. Thank you so much. We cannot express how much we appreciate this.
Of course, of course. Bye.
All right. Take care. Good night.
All right. So we are about to send out the link for the quiz. You'll have about an hour. Let me go ahead and get that sent to you guys. We'll also put the link in our bio on Instagram. And yeah, as long as you get 4 out of 5 right, you'll get the certificate.
Awesome. So thank you guys so much again. Keep an eye on the chat. That's where we will be posting the links as well as the Instagram bio, like she said. Stay tuned because we have a ton of speakers coming in November, some as soon as this weekend, a lot next week. So like we said earlier, you guys can get a lot of experience, a lot of good information on that, and a lot of shadowing hours as well, potentially, if you do all of those quizzes. So yeah, guys, thank you so much. We're still going to be in the chat, but we're going to go ahead and end it right here. Thank you very much. We appreciate it.
Bye. Thank you.
Take care.